Good evening, everybody. Both here in person at the Annenberg Center and also on Zoom tonight. We're really pleased that you're all here because we're going to have some fun tonight, show you some interesting things. Not me, though, but somebody else is going to do that. These guys right here are going to do that. So we're really pleased to have you here tonight. We're in a partnership with Eisenhower Health here to put on these lectures once a month from October through June. And we have a whole series of things. We have cardiologists, surgeons, we have registered nurses like tonight. Come and talk to us about how to live with heart disease, get us smarter and educated about that. And it's a wonderful thing, and we enjoy having you all here and on Zoom as well. So we're raining here in the desert a little bit tonight. So that's for anybody that's out of the area. It's like, you don't have rain in the desert. Well, once in a great while, and we could sure use it. So that's a good thing. So we're going to have a question period after their presentation. So if you have any kind of questions that you'd like to ask these two folks here, please do not hesitate. We'll get all that done too. And they'll be staying around a little bit afterwards too. Once we get done with the actual Zoom thing here tonight, we will have a support group session afterwards, and you can sit around and talk to people that have been through fellow heart issues like you. And it's a wonderful way of sharing that and getting some questions answered by people who have been through it just like you. And we have we have Lydia Vincent back in the corner over there, who's our medical consultant for all of this, and we appreciate that too. So it's really good. So we kind of thought about, you might be interested in seeing some of the tools that they use in the cath lab. And they brought a few of those things here. They've got a presentation to do it as well. So we're going to do it. So I'm going to introduce Wade Little and Monica Colgan. And these are two of these guys, excuse me, guys and gals. One of a guy and one of a gal. Sorry about that. Wade has been here in the hospital for about, 22 years?
22 years.
22 years. In the cath lab about 11 years or something like that. Monica has been working in the cath lab for about 4 years and came from a ER background, an ICU background, right, in another place. So please welcome both of them, both RNs, and please welcome them. They're going to get right into this presentation. So,
thank you.
Thank you. Thank you. We'll do a quick moment of just introducing ourselves so you kind of understand our background. Bill did a great job, of course, giving a cursory, but that way we can build a little rapport with you. And that way, if you see us in the hallways or if you see out in the community, please don't hesitate to come and just say hi. If you have any further questions, we'd like to keep the questions kind of at a minimum during the presentation. I know people maybe want to get home because of the rain issue. We can make sure it's efficient, get it done, and then afterward, I have no limitations. I can be here all night if you need me and answer any question you might. So
I've got little kids to get home too, so I can't be here all night.
So we're going to kind of do a back and forth dialogue. She's going to do a slide. I'm going to do a slide, and then we'll just go from there. So I'm going to give the floor to Monica, please.
All right. I'm Monica. I've been here, like he said, for almost 4 years. I started in ICU as a new grad and was able to work in a level 2 trauma center where I did a little bit of everything. I did a lot of pre and post cath care, post MI, pre-MI, traumas, car accidents, strokes. I've done a little bit of everything. And before that, I started here at Eisenhower back in 2011 or 12 as a CNA or nursing assistant while I was doing all of my schooling. So I've quite a few years also in the hospital, but just not as many nursing years as Wade has. I have a couple little girls at home, 2 and 4, or almost 2 and 4. So I'm quite busy, spend a lot of time here with all my coworkers. Best team I've ever worked with. And yeah, I'll hand it over to you.
Yeah, so my name is Wade Little. I've been at Eisenhower for 22 years. Actually, of January 17th was my hire date. And I did approximately 10 and a half years in the ICU. I was officially the first new grad ever invited to be an ICU nurse. And the director at the time said, if you don't work out, I'm never letting another one come. So as you can imagine, I was very stressed. But it's what I wanted to do. I love the concept of caring for the sickest of our community. and hopefully learning the information, the knowledge it took to help them survive their process. And then ultimately I learned even more so, nursing is about helping people cope with their process, and the families especially. 10.5 years of that was wonderful, but it's a very taxing job. So at some point I had to move away from that and find something that was not as intensive in a lot of ways, but later I found out not exactly less intensive. So I thought procedural would be wonderful. In the cath lab, I was a student. I went through the cath lab, and there's a gentleman in the back named Steve. And actually I remember him when I was a student, and they were really, I loved this concept. So let's go from the ICU to the heart. So I've been in the cath lab for 12 years, or 11 years, excuse me. And it's amazing. It's an amazing place. As many of you maybe are the recipients of our care. Maybe some of you are going to be recipients of our care. But as you know, it's a wonderful team. We've got a great team of doctors, and the staff here, I would put them up against any of the institutions that everybody brags about, Hoag, any of them. And actually, we're finding that our accolades are actually showing that, and our statistics are showing that. I also have a daughter, 7-year-old. I was an older parent. My wife works in the special procedures, so we're both nurses, and we love the community. So anyway, we'll start with the slideshow, and we'll go from there.
Alrighty, so cardiac catheterization. Cardiac catheterization is the insertion and passage of small plastic tubes or catheters in and out of your arteries and veins to obtain pressures, and also to take pictures of all of your arteries.
I'm going to look at this screen just so I'm on my back to you. It's a little easier. So these are the procedures that are basically performed in the cardiac cath lab here at Eisenhower Medical Center. And we are really becoming a center of excellence when it comes to cardiac, obviously. So you start with the meat and potatoes, the left heart catheterization. We have both sides of our heart, the left and the right. The left gets all the attention. It's the part that pumps blood to our toes and our brain, our kidneys. So the right is the little stepchild of the left. So, but we still look at the right heart cath, and we'll expand on all these bullet points in future slides. So we'll explain more. The coronary angiography, that is actually taking the pictures of your arteries that feed your heart muscle. We don't use dye. Dye is a terrible word to use in the cardiac cath lab. Dye is what makes this a burgundy color. Contrast is what is used to see the arteries. So we don't use the dye word. Bypass graft angiography. Those of you that have had bypasses, sometimes unfortunately in the future, you might need to have them looked at. We can also engage those and do the same thing. Now, that's the diagnostic aspect. We're getting pictures. We're finding out the information we need. Once we find that you maybe have something that is amenable to balloons and stents, et cetera, then we move to intervention, and that's the next bullet point. Percutaneous coronary intervention, we'll use PCI as our acronym just to save time tonight. We can do angioplasties, which are the balloons, PTCA, coronary stenting. If you're gonna balloon an artery or a graft, you have to stent it. It's like a pimple in your nose when it's deep. It hurts, you know it's there, but if you push on it, it's gonna become a whitehead in the morning. If we just go and angioplast an area of disease and we don't put a stent in, it's gonna shut down in the future. So we very rarely will angioplasty only and not stent. Atherectomy. Atherectomy is the concept of coronary artery disease is a chronic disease process. They've even shown, unfortunately, in babies when they do their autopsies, they have pre-plaques in their arteries already. So you develop this over a very long time. Your body sees that as a long-term process. You lay down calcium as a protective nature. Calcium's a rock, it's hard. Unfortunately, when it comes time to fix it, it's hard like a rock. So we use equipment that have diamond tips and diamond aspects of it, and we spin them at an exceptionally high rate. Like when you go to the dentist, that's as fast as we spin these things, and we debulk that calcium. It pulverizes it to such a micron level that you actually absorb it through your capillary bed. If we don't debulk it, it can be very dangerous to plasty it and stent it, and or you can even plasty it or stent it. Next one's thrombectomy. The major reason for major heart attacks is the clot formation, and it's in an artery. It shuts down the blood flow. We go in there with vacuum cleaners, basically, Got really fancy, awesome ones. They're very small. And we suck that clot right out of the vessel and it opens it up and you feel better. And then one of the more exciting things we're doing right now is this intravascular coronary lithotripsy. Anybody that's unfortunately had a kidney stone has had a lithotripsy. You send pulses of sound waves and it breaks up that calcium. So instead of having to spin that diamond tip blade at 170,000 RPMs, we can put a balloon in there that pulsates and it sends sound waves and it pulverizes that calcium. So that's very exciting, safer, wonderful stuff. Peripheral angiography and intervention, we do legs in the cath lab and we do kidneys. We don't do a lot of them, but we can do that. Anything with the brain or the belly, that's all interventional radiology. We don't touch that stuff. Structural heart procedures, that's the big buzzword right now, TAVRs. Everybody loves TAVRs, right? We're fixing people's aortic valves without them to cut their chest open. It's a magnificent procedure. It is wonderful, and the outcomes we see are incredible. People come in, can't hardly live their life, and we return them to a life of better than it was 20 years ago, for example. Aortic valvuloplasty, some people don't need the actual stent of the valve put in. We just have to open it up a little bit. That's used there. The clip or mitral valve repair clip, and actually we're doing some other stuff. We're going to start clipping other valves, but the mitral valve right now is where we'll focus. Anybody that has mitral valve regurgitation, where the valve should only go in one way, but sometimes they go both ways. It goes back into your lungs, you feel terrible. We go in there through the vein, everything's through the groin, basically. And we put a clip, and in fact, back there on the back table by the food, there's a wonderful little rendition of what a clip looks like on the mitral valve. And we have to capture that clip, that valve, while it's moving. So it's very difficult and very laborious, but people do very well with it. Then septal defects. These are the things that people have when they're born. It's genetic. Sometimes they get it done when they're children, babies. They know it right away. But people can live an entire lifetime and not know they have a septal defect. We put these special little closure devices. They look like hi-hats on a drum set. And it's where you have a hole between the septum of your heart. We put these two cymbal-like items, we squish them together, we release them, and now they seal up that part of your heart. And that's all, again, through your groin. Another wonderful technique or technology we have are these mini heart pumps we can put in. We use your groins for that. We can actually go through your underarm. And actually, if you need a little extra insurance or support during a procedure, we can put these in. And now we're safe to work on you, even in the most scary of interventions. These save people's lives. They're magnificent. In fact, within the next 5 to 10 years, I bet you it won't be time or ER to balloon. It'll be ER to one of these because we're unloading the heart. That's almost more important. And the last one, we actually have gotten to where we're putting a lot of permanent pacemakers in. EP Lab's overwhelmed. And then we also have the Micra, which is a little tiny guy. It's about the size of my pinky. We go through your groin. It's got little fish hooks, basically, and we'll go into it. And it lives in your heart, and now you have a pacemaker, and we didn't have to cut you open. You don't have to have the restrictions. It's an amazing technology.
Righty. Okay, so indications for heart caths, reasons that you'd be coming to the lab to see us. We have acute coronary syndromes, unstable angina. So this is going to be your chest pain, symptoms of a heart attack that are not relieved by relaxation or rest, and typically lasting for about 20 minutes or longer, not relieved by nitroglycerin as well. We have NSTEMIs, your non-ST elevated myocardial infarctions. That's going to be someone coming into the ER who is having chest pain, symptoms of a heart attack, and accompanied by a troponin increase or a troponin bump. That's an enzyme that our heart or that our body releases when our heart has had some sort of damage to it. So we have to have those both together to classify it as an NSTEMI. Then we have our STEMIs. Those are our ST elevated myocardial infarctions. For those, Same symptoms. You often have the troponin release at some point, often after the event. And then you have the chest pain, symptoms of the heart attack, accompanied by a change in your EKG. So that's why our EKGs or our 12 leads are so important when our patients are coming to the ER. We're able to see and sometimes identify the part of the heart that's actually being damaged at that current time. So that's what's going to classify us as a STEMI. That's what we get called in for in the middle of the night. Those are our emergency situations. We have suspected or known CAD or coronary artery disease. These are the patients that have already been to the lab, likely know that they have disease or maybe a 30, 40, 50% blockage somewhere that we just never fixed, because we are not going to place a stent or fix anything unless we're over about 70% blocked. So maybe they're having symptoms now, they're doing, they're out walking, they're doing stairs, now they're getting pressure in their chest, they're having some sort of symptom that's telling us that maybe that disease is getting worse. So that would bring you into the lab. New onset angina, so also someone's out hiking, they start having chest pressure, that's a good reason to come to the ER, get checked out. Maybe you don't have the troponin release, maybe you're not currently blocked or causing an acute event, but you maybe have a blockage, and we'll go ahead and check you out and fix that if needed. Abnormal stress tests and CT angiograms, oftentimes also having symptoms maybe outside of the hospital, and you're going to your primary cardiologist or your primary doctor, and they're saying, let's go get a stress test, let's see if there's something else. We can tell a lot by these tests. And a lot of times the CT angiograms, they're not always accurate, but it gives us a good reason to look a little bit further if we're seeing a bunch of calcium on your vessels. Sometimes that calcium's on the outside of your vessels, which is good because we don't have blockage inside the vessels, but sometimes it is inside the vessels, and we can go ahead and fix that.
Can I add to this?
Mm-hmm.
Okay, so the abnormal CT angiogram, we're seeing that quite a bit more is the ticket to ride to the cath lab. That's what gets you on my table. And it's a wonderful new diagnostic technique that the cardiologists are using. We apparently have a wonderful one at Eisenhower's disposal. When you get a positive or CT angiogram, please do not panic. We're finding more often than not, they're not actually causing the need for a stent. But what it does do is it shows calcium on the artery. And there's 3 layers of your arteries. There's the outer, middle, and inner. We're more concerned about the calcium or the disease on the inner level, because that's the part that actually drops in and blocks the flow. You can have it on your outer, you can have it in the mid. This cannot determine that just yet. So it'll have a positive high calcium score. They'll want you to come in, you're nervous, you're freaked out. Oh my God, I gotta go to the cath lab. I find anecdotally, less than 10% of our patients that have a positive CTA actually end up needing a stent. Because what we do is we get in there, we shoot the contrast, and the disease is in the layers of the artery, but it's not impinging on the flow of blood. It can't do that yet. But why it's a valuable tool is the average person that's walking around feeling relatively well, and the doctor thinks you're a high risk, they'll order this. You might have not come to the cath lab, and we save you from having a dramatic and traumatic heart attack or life-ending event. So it's a wonderful tool. It's well worth the time, but just don't freak out if you get one, okay? And if you're just going to get a stent and you don't, well, no, it's beautiful. Then don't be upset. Sorry, we didn't put a stent in you.
All right, so then we have evaluation before non-cardiac surgery. So that's if you're going for a shoulder surgery, a hip surgery, any orthopedics, plastic surgery. Oftentimes, if anything came back abnormal on your EKG or any of your prior testing, then they're going to want you to come to the lab, get another test, do a cath procedure, check out all of your arteries, because it just wouldn't be safe for us to be put under anesthesia without knowing what our arteries look like if there's anything abnormal. Cardiogenic shock, these are going to be the patients who are having full cardiac arrests. You're out golfing, you fall down, full cardiac arrest, you get brought into the hospital. We're going to go ahead and bring you into the lab as soon as possible. We hit the ER, come straight to us. So oftentimes that's because of a blocked artery, a really bad lesion that has caused that. So we can do things like you talked about, the left ventricular assist devices, the Impellas, things like that to help support the heart if we can get you that far. Valvular heart disease. We do a lot of left and right heart caths on patients who are needing TAVRs or the aortic valve replacements. And then we can also look at the other valves as well. So before any TAVR procedure, you have to have all of the other workup. So that means a coronary angiogram, pictures of all of your arteries, as well as your left and right heart cath. And together, we're able to collect a bunch of numbers and information that tells us the actual diameter of your aortic valve. So it's going to help us compare to what your echo said, or how narrow your valve was on the echo. It gives us a little bit more information before going forward with the valve replacement. Pericardial effusion, tamponade. So this is going to be fluid around your heart. This is patients often with cancer, right? We have a lot of fluid buildup. Unfortunately, it builds up around the heart. A lot of blood collects around the heart. And sometimes that squeezes down on your heart where it's not able to pump effectively. When that happens, we're able to bring the patients into the lab, insert a little needle and pull out all that fluid and allow the heart to pump fully and relieve some of those symptoms they're having. Heart failure. Another good reason for a right heart cath, patients with shortness of breath, low ejection fractions are going to come to the lab to look at our right heart cath numbers, our pressures in all of the venous side of our heart. It's going to tell us a lot about your fluid system. So patients on diuretics, this is going to tell us a lot about, do you need more diuretics, less diuretics? What can we do to manage those symptoms? Due to heart failure. And then broken heart syndrome, Takotsubo cardiomyopathy, or stress-induced cardiomyopathy is another great reason to come to the lab. These mimic STEMIs or heart attacks often. So these patients have the pain, the chest pain, all of the symptoms, often have the troponin release. They look like a heart attack when they hit our doors. So we get called in for these. But what they are is a change to the way your left ventricle is pumping blood out to the rest of your body. So it's limiting the amount of flow that we're getting to the rest of our body. And we have a picture of it coming up. And how it changes left ventricle. So it'll be a little more interesting when we get to the picture. Anything?
With the broken heart syndrome or Takotsubo syndrome, taco, if you ever go sushi, that means you're eating some octopus.
Mm-hmm.
Takotsubo is the word for the octopus trap. So we'll get to that. But this is that concept where you've heard on the news, somebody's spouse passes away, an animal passes away, and they die of a broken heart. Well, it's real because the stress of financial, personal loss, illness, even like a COVID infection, for example, can put so much stress on your body that your adrenal glands pump out your glucocorticoid steroids, your adrenaline, your norepinephrine, et cetera. That influx of adrenaline can make your heart become misformed. It actually blows the apices of your heart out. It's like you overwork the muscle and it makes it all boggy and fat, where the center part is kind of conical. So it's people that die because their spouse dies very shortly after. This can be an attribution to that. Like they have a heart attack and they die. Well, yeah, because the stress of it is incredible. We had a guest at our lab on one time. She got rushed into the ER. We thought she was a heart attack. Well, she was speeding down Bob Hope. She got pulled over. She was so overwhelmed by the stress of being pulled over that he had to call 911. She was having a heart attack. When the EMS showed up, they put her on the ECG. She was having a heart attack, ST, elevated myocardial infarction. I was on that day. I got called in. It was a Saturday, noonish. Rush in, get in there, and she's panting, and she's got all the symptoms, chest pain. Her arteries were gorgeous. Pristine. I hope mine are that good right now, which I doubt they are, quite frankly. And unfortunately, the stress of being pulled over was so much that it caused her to have Takotsubo syndrome.
But she got out of the ticket.
So. Okay, so we'll move on to the next one. I know it's long. I don't want to keep you. Okay, so I think the Monica and I put this slide together because we want to show that there are differences for men and women. And I think we always focus on men's health more often than not. I think hopefully it's trending the other way. But these are the symptoms on each side, of course. And you can read the top part if you like. But of course, shortness of breath, fatigue, chest pain. Men tend to feel like they have an elephant on their chest. They'll say that. Actually, I've heard that said. Jaw pain, down their arm, etc. Women, on the other hand, have can have exceptionally different symptoms that are not specific. So for the ladies in the room, I want you to maybe look at this, take a picture or whatever, but your big toe can hurt. Have no other symptoms. A lot of times it's epigastric pain. You think you're having heartburn, or you think you're having bowel issues, nausea, vomiting, etc. Feeling of full, you're belching a lot. They do have chest pain, and they can have the same symptoms. Shoulder pain, back pain. One of the biggest things I tell people is trust when you feel like you're having an undescribable reason for having fear or anxiety. Trust that feeling. That's maybe something going wrong. So anyway, that was what this slide is for, is just to kind of show you that although we're a lot of same, we're a lot of different. And for you ladies in the room, let's not just, don't listen to the chest pain and the, you've got.
Listen to that too, but.
Yeah, listen to those.
Listen to that too, but
But
the
yeah,
other
your
symptoms are
pinky toe
important.
hurts, and I mean, that's a really obscure one, but I've actually heard that. So anyway, next slide.
So different catheterization. So we talked about, or Wade talked about left and right heart caths a little bit. So here on the left side here, we have the left heart. And for us, when we classify it as a left heart catheterization, we have to have a catheter that goes into your left ventricle and crosses that aortic valve. As soon as we cross that valve, get some pressure or number readings, and sometimes take a picture with our contrast, then it's considered a left heart catheterization. This specific image is a left heart, or a left ventricle, and this is an example of the Takotsubo cardiomyopathy. So this is not what a normal left ventricle looks like, but this left ventricle looks like a Japanese octopus trap. So this is a broken heart syndrome, Takotsubo, stress-induced cardiomyopathy on the left there.
This is what a normal one looks like.
Yeah,
basically.
We want to have this shape more so. And then on the right here, we have the right heart catheterization. This is going to be with a very specific catheter called a Swan-Ganz catheter. And we can either access, this is a venous side of your heart. So we're going to be accessing either your arm, your neck, or your groin vein. And we're going to get pressures throughout that entire right heart system. That's going to start in your right atrium, go through your valve, your right ventricle, into your pulmonary artery. And then we have a cute little balloon that's unfortunately broken on that model. And that balloon, or that tip of that catheter, will sit in the pulmonary artery. We blow up the balloon and we're able to get pressures on the other side of that, which tells us a little bit more about your left atrium and your mitral valve. And then we're also able, with this catheter, we're able to get a lot of different information. Aside from just the pressures inside your heart, we're able to get number readings that tell us about how much blood flows in your body. The cardiac output, normal output's about 4 to 6 liters of blood flow. We're able to push room temperature saline through your heart, and it's able to create a number reading off of that, how long it takes for it to hit your body temperature, and gives you a cardiac output or a flow reading on that. And then with that right heart cath, we're looking at a few different things. We're looking at heart failure. These are going to be your heart failure patients. Like I said earlier, we're looking at fluid status because all the numbers are going to relate to fluid status. And then also the congenital heart defects, our ASDs, our PFOs, so our atrial septal defects, or our patent foramen ovales. We're able to look at whether there's a hole somewhere in your heart based on our oxygen saturations in the blood. And what else? Valves.
This
very important for,
this is
for valves or TAVRs.
Get your valves worked on. It's part of the check boxes. We cannot give you a valve unless we've done this part.
Yes, and pulmonary hypertension. These numbers are also going to tell us about that system as well. So I think, anything you want to add?
I think so. Do you like me here or over there? Where do you like me better? Over here? We're framing the picture better. We wanted to throw in just a simple slide. This is off the internet. We didn't cite it because it's benign, but this is what the cardiac cath lab theoretically looks like. And ours doesn't look too unlike this. Obviously a lot of equipment, a lot of fancy stuff, but you know, in this case,
we spared you the blood and all the extras.
Yeah,
Mess.
This is the physician. Let's just call it what it is, the patient. And this arm is the C arm. That's an X-ray machine. A lot of people think that we put a camera in you. We do not use a camera. We use an X-ray machine, and that's on a gimbal. We can basically do a 280-degree rotation around your entire body, or 360 this way, but also 280 around this way. And we just take injections, and on the screen on the right, you can kind of see some rendition of arteries. And for example, we have that exact screen in our labs, and FYI, it's only like a 70-inch screen. So you buy that at Costco for $700. That's $100,000. We've gone through 6 of them. So yeah, it's an exceptionally expensive piece of equipment. All of it is. They're about $1 million just for the X-ray equipment. So we're about to expand. I think we're going to have close to 7 labs here very shortly that are intermixed. So you can imagine the capital investment that Eisenhower, our generous donors, that have done for us. So we're going to be able to meet the needs of our community that much better.
All right, so here's an image of a right coronary artery. This is a very normal right coronary artery. Looks like a big C, covers the inferior or back posterior portion of your heart.
This is the left coronary artery. This is what gets a lot of attention. So the first aspect right off the catheter, that's a catheter. They're about 2 millimeters in diameter. We're talking millimeters here. That's your left main. That's arguably what realistically you've heard, unfortunately, the undesirable word, the widow maker. If that shuts down, most of us don't survive, actually. We can save people, but it's a time issue. So if you're feeling chest pain, don't drive yourself in or put it off. Call 911, get in an ambulance, and get to Eisenhower. You don't want that to go down when you're driving. You could not only not do yourself any service, but you're going to hurt the community. Anyway, it bifurcates or forks mostly to 2 types. It's like throwing a left-handed fastball. Your heart's here. That was the right. This is your left anterior artery. It's left anterior, so it's on the anterior wall, the front of your heart. And then the other bifurcation of the branch is your circumflex. It runs down your lateral side of your heart. The LAD is second in importance in reality. You can see it comes all the way down to the apex of your heart. This is where your heart is, and this is the artery that reaches all the way down. So if something goes bad with your LAD, you're in trouble, big time. So that's just the anatomy, and that's a coronary angiogram. That's the contrast flowing through your artery.
These are very normal. This is what we want our arteries to look like. All right, so PCI, Wade already kind of covered a lot of this. We'll go over some images. We have some videos to show you on all of these things. A few different options for coronary intervention. We have balloons where we can balloon a vessel only. Stent where we can place the stent. I'm not going to go elaborate too much since you already kind of did. The coronary atherectomy, that's the removal of all debulking of the calcium in the arteries. Thrombectomy, removal of an embolus or a blood clot. And then the coronary intravascular lithotripsy, which is shockwave or sound waves to break up that calcium.
PCI indications or percutaneous intervention indications. This is why we would move into intervention after we took our pictures. So as Monica had alluded to, we don't just put stents and fix everybody's arteries. The studies show that unless your arteries are anywhere from 70 to 80% narrowed, it's like the drain in your sink, there's not all that hair and goop, and it's more than 80%, there's no benefit in us going in and fixing it. In fact, the risk of taking blood thinners and having us blow balloons up and do all this stuff actually outweighs the benefits long-term and even short-term. So we only fix things that are, let's just call it 80%. So you're having angina. Angina is the word for chest pain. When you go to the bicep curl and you're doing it really good and it burns, that feels good, right? We love that. But when it's in your heart, it's the same behavior. It's an anaerobic activity. Your heart's always beating. You can't stop it. But when you close blood off, you don't get oxygen to the muscle. It becomes anaerobic. We love this burn. Your body's built to not like this burn. That's chest pain.
The heart is the only muscle, the heart is the only muscle in the body that cannot withstand having oxygen removed from it.
Right.
Any other muscle can live. So
angina causing sufficient symptoms, your blood pressure's low, your heart rate's high, you're sweating, you just feel terrible all over. Despite you're already on your optimal therapy, like if they've optimized your therapy and you still have angina, now we got to do something. A lot of times we'll take people in the cath lab, they're having angina, but they're not on the right blood pressure meds. They're not on the appropriate, like the medication cocktail, I guess if you want to call it. They'll sometimes use that first, and then they'll put you on this. mild angina with objective evidence of ischemia. So you've had a stress test, that CTA, you've got ST elevations. You're really showing us that you can't not get this done, really. Acute coronary syndrome, that's the non-STEMI and STEMI. Non-STEMI, non-ST elevated myocardial infarction. You know the EKG we see everywhere? STs are after the neat little big one, the QRS complex. The STs are afterward. They should be isoelectric on the same line. If you have elevation in there, then we know you're having injury, ischemia, and necrosis of your heart muscle. So you're going to get that. The NSTEMI is that you don't have necrosis, but it's bad enough to elicit some injury to your heart muscle and you're releasing troponins into your system. The STEMI is the worst. The non-STEMI is very serious. Angina after a CABG. You might actually have gone to the cath lab, determined you needed open heart surgery. You got your open heart, and for some reason, something closed down, a blood clot. Unfortunately, it can happen. It's very rare. I think in my 12 years, I've had to go back twice. And so don't fear your CABG. It's very rare. Restenosis. So we went and put a stent in you. You did the best you could do. We did the best we could do, but for some reason you will elicit more disease and you shut down your stent, whether it be scar tissue or whatever. We will have to go in and actually open that up again. And then the last one, which I think is very interesting, we get a lot of patients that come in with new arrhythmias, atrial fibrillation, atrial flutter, ventricular tachycardia, VFib, which is not life-sustaining. If you have a new onset of an arrhythmia, one of the number one reasons why you have that arrhythmia is because your muscle's not getting enough blood flow. You might not be having chest pain. You might not have ST elevation. You might not even have troponin leaks. But it's reasonable, if you come with new AFib, for us to take you to the cath lab and just make sure you're getting a good blood flow. Because if you're not, and we can fix it, we can actually sometimes reverse your atrial fib, for example, potentially. Next slide.
All right, so contraindications to percutaneous coronary intervention. So unsuitable coronary anatomy. So that's going to be when you have maybe a left main that is really calcific, like we mentioned in the next one, could result in death. I'm going to combine these together a little bit. Some of these patients, it just doesn't make sense. So maybe this is age-related, a mixture of things where it just isn't safe for them to either go for open heart surgery or for us to go ahead and open up that artery without the risk of death. Sometimes these patients still choose to go ahead and have everything done. And then we would use an assist device and try to go ahead and open things up and support them the best we can. The other reason they would have unsuitable coronary anatomy would be too small of vessels. The smallest stent we have is a 2.25 millimeter stent. And if we can't get that stent in there, then we're not going to be able to do anything for that artery. Oftentimes we find a very distal or a small blockage that's further down in the vessels in a very small area where it just doesn't make sense to go in there and wire and open up. Abnormal bleeding. Every once in a while, we come across patients that have different clotting factors than the norm. If that's the case, sometimes it's not safe for them to be on dual antiplatelet therapy long term, which is something that's necessary when it comes to placing a stent. Or we just have to figure out coagulation, or patients that are also allergic to aspirin. This is another big one. If we're allergic to aspirin, oftentimes our doctors are going to try to taper them on to aspirin and see if we can figure that out first before we place any stents. Non-compliance to dual antiplatelet therapy for confused patients or patients that don't have a whole lot of support, family or friend support at home. If they were to miss their dual antiplatelet therapy and we had placed a stent, it would be more harm than good for these patients. So a lot of times this turns into just medical management. We're going to give them medications, try to optimize, try to make sure that the disease doesn't get worse, and just optimize what we can, treat their pain with nitroglycerin. Multiple in-stent restenoses for the patients who have had stents placed and they've closed down a couple of times, 3 times, 4 times. It's not safe for us to place more stents because they're obviously more at risk for that happening over and over again. Patients who cannot give informed consent, again, confused patients, someone that's just not on board with doing the procedure, we're not going to go in there, place stents, or do things that are going to, further risk being on dual antiplatelet therapy, or someone that's just not really aware of what's going on. Anything to add?
Nope, that's good. Didn't want to cross over while she was talking, so, but I had to get a drink of water, sorry. Okay, so this is percutaneous transcatheter coronary angioplasty. So on the left is a video, this is a pacemaker, but you can see really how tight it is after the left main into the LAD. Again, the LAD comes to the area, but if we'll play that again, Aaron, if we can, thank you. So you can see it's really tight. I mean, I don't know if you can, but it narrows down.
I'll
It's like a
point to it here.
napkin ring. Those of you that like to put napkins out during,
There we go.
it's
right
a napkin ring. Yep, right there.
And then you can also see that there's a stent in place there. So there's already a stent.
Yep, there's already a stent actually there. So that would be a narrowing. I would estimate that just off cuff about 85, 87%. So it meets that criteria. They're having issues, 85, more than 80%. So, and you can kind of see the halo of the stent. So then we go in and again,
We've just highlighted the.
Yeah, highlighted there. So, okay, so that's pre.
There's post. Go ahead.
Oh, okay,
There.
so this is post. This is a balloon over wire. We use wires for everything we do in the cardiac cath lab. A train cannot run without a train track. We cannot put any equipment in your heart unless we have a rail to work off. So we use wires. So catheter, that same area that you saw previously, and there's a balloon. There's two dots that indicate the size of the balloon so we can measure it perfectly. We inflate that balloon for a relatively short amount of time because every time you inflate that balloon, we're causing you a heart attack. We just stop blood flow to your heart muscle. So we do it for very short times. At the max, about a minute is all we can justify before we're gonna hurt you basically. But that's what that does. And you can see it's filled with contrast. We never fill these with air because if that was to rupture with air, that would cause you to have a heart attack. Air and blood do not mix. So that's why we have contrast. Plus it allows us to see it. And then you can see right here, wonderful result post ballooning. It's almost like it's brand new again. This is one of those cases where you might not go put a stent back in because they already had a previously existing stent in that area. They developed disease within that stent. And if the physician or the patient or whatever extenuating circumstances didn't allow them to maybe get good follow-up, they might just feel it's reasonable to open that up because you already have the girder system. It's like the framework in a tunnel that miners do. They put the wood up and stuff. That's basically all we're doing with a stent. We're creating a matrix of metal to keep the tube open. So that's that.
Also kind of interesting, we also see pacemaker leads on this one. We look at a lot of black and whites all day, so we can see a lot of different things. Like we saw before, we're looking at it, we can already see the outline of where our stents are. And then we have a catheter going up and around. We can see the difference in the wire here. And then we also have two pacemaker leads, both an atrium and a ventricular lead. So that's a dual chamber pacemaker.
These are ribs. Those are your ribs. And those are like looking at a rib, basically. Diaphragm, etc. So we see a lot of stuff.
Alrighty, coronary stenting. So here's a pre-stent image of an LAD, a left anterior descending artery, kind of pointing out obviously that lesion area. Also say probably about 70 to 80% blocked there when you compare the distal flow. And then over here, this is the stent balloon being inflated. You can see the two dots that are giving us an outline for where our stent borders are so that we know that we're covering the whole area that's diseased and we're not leaving any area out. So that's what we use for measuring. And then that's the balloon blown up with a stent around it. And then here's our post. So you can see the difference in our stent, and our post stent right there. Fun fact, this is someone in the room. I've already confirmed it's okay for me to share that. So this is someone in the room.
One of your parts.
That's over, I mean, this is a stent that's over 11 or 12 years old at this point. Maybe more.
Okay, so now we're gonna get into some of the really fun stuff. This is the neat, well, not new, but stuff. So this is rotational atherectomy. This is that part where you got disease and you've had it long enough and you've made calcium. So the white is indicative of calcium. That tip has diamonds embedded in it, crushed up diamonds, of course. And it spins on a shaft and it burrs. It has a cutting function at the nose cone. And we spin that again anywhere from 160 to 170,000 RPM. It is incredibly interesting. People are like, I thought I was at the dentist. So So we're debulking that area before we can go in with balloons and stents, because without that, there's no way you can get anything done. And there's a stent over a balloon. We expand the balloon, it stretches the stent, struts out. We do an aggressive inflation, and then now you've got an open pathway. It gets so pulverized to such a micron level that actually you were able to absorb it through the pores of your capillary bed. So it just gets kind of absorbed in your body, and I'd like to think either you excrete it out or your body says, oh, look at all this great calcium. Let's use it. But I don't know that. Can't speak to that part.
Not sure what happens with that part, but here's another form of atherectomy. This is another device or tool in our toolbox. It does the same thing.
Device
it's debulking
is uniquely
calcium,
designed for calcium.
but with more of an orbital feature.
enables-
So as opposed to a burr going straight in and out, it's going to spin around and debulk that calcium in that way.
It's like the football you saw Jalen Hurts throw on Sunday. It's football. And the faster you spin it, we've got two settings now. The slower you spin it, the smaller the orbit. So we start slow and we kind of make our way through, and then we increase those speeds, and then it gets more wobbly and it makes a wider cut. It cuts on the side, it doesn't cut in the front. So you have to be able to get this piece of equipment into the calcific area to able to make it effective. Where the other one, you could burr from the front. So just depends on where it is, the safety, if it's the appropriate modality for it, et cetera. Those are red cells kind of flowing through your system.
So what it's showing is that all of the calcium that's breaking off is smaller than a red blood cell. So when we're looking at our particulate size, here's a red blood cell, white blood cell, obviously how tiny it is. So it moves downstream. We don't worry about this getting stuck or creating anything downstream or having any issues. Not from this, only because it's becoming so small that it's not going to create anything anywhere else. We don't typically have issues with that. I mean, on occasion, I mean, so when we're using this, we're doing it with calcium, right? We're not using this in any soft plaque. If we're using soft plaque, we're just using balloons. We're smashing it up against the sides of your arteries. With this is only for calcific areas, where if we were doing it where there was soft plaque, maybe that could move downstream and cause an issue. Or if it were to move or rupture, then that could cause a different type of issue too, or a more acute issue. But most of the time, this is only happening in calcium. We're pretty certain of that stuff.
The risk of stroke is really small when you're actually in the intervention process, because you've already got your catheters across the area that could potentially cause stroke. It is a risk. But when you're breaking down plaque and stuff in the arteries, the only way they can go is downstream, which downstream means you're going into the heart muscle, the capillary bed. Even if it's a big chunk, it will never get back to the return venous side and actually go to your brain. It can't. It's not even an option. So PCIs are really safe once we start the PCI, the intervention process. There is a mild, very small, but very mild risk of when we put our catheters and stuff over the arch that we could accidentally knock loose a plaque or something.
Calcium
Could
or something.
potentially migrate up
the
carotids, and you could have a stroke. But when your physician has that dialogue with you and he explains or she explains the risks and benefits, stroke is definitely one of the potential unfortunate outcomes of what we do. That's why we don't take, even at the nursing level, and everybody in the cath lab at Eisenhower, every member of the team, whether the RT, the radiology technologist, the scrub, or the nurse, we are very cognizant of your safety, and we do not take even the basic diagnostic angiogram lightly, because bad things can happen.
Very fast.
Minimize those because we're so fantastic. Well, you do one or the other. So if we can fix you with the orbital atherectomy or the rotoblator atherectomy, you're going for stent, you're going for PCI, you're getting cath lab work done. The reason you get a CABG is because none of our tools, none of our modalities, the physician, your anatomy, your disease process eliminates us as a reasonable, viable option, where the risk of you dying or having a bad outcome way outweigh what the risk of actually having a heart surgery is, which sounds crazy, but it's true. It also has a lot to do with age. I mean, if you're a very, very, very young person, you know, stents last about 10 years on average. I mean, I think that a lot of that has to do with our lifestyle in the Western world. We continue to eat in and out and cheese and cookies, etc. But
Lifestyle.
it just is what it is. And heart surgery can last much longer. So sometimes it's a better option. And then there's other viability issues with if you're a diabetic, you know. So there's a lot that goes into that. But if you're going to commit to this, the doctor and you have said, no, I'd rather try this option than having open heart surgery. Now, having this option done, depending on where your disease is, does not omit you from the potential to have CABG in the future. And that is something that the doctor does take into consideration.
And there are also situations where we would choose the option of going towards cardiothoracic surgery as opposed to stenting. And that's going to be, I mean, a few things he just mentioned, but also if you have multiple blocked arteries. If you have more than 2 blocked arteries, most of the time we're going to take you off the table and say, hey, we should talk to a cardiothoracic surgeon, see if that's a better option for you, and weigh all those other risk factors before we make a choice to do this.
Okay, laser. We have a laser at Eisenhower. It's wonderful.
Photoablation properties of the excimer laser.
And it's the same thing. You've got this really dynamic plaque. Maybe you can't even get our smallest of balloons, which is 1 millimeter in diameter. It's basically barely bigger than a piece of hair, really. And you can't even get it through it. Sometimes you can't. It's super tight. So at that point, we have this new technology, and it's been around for a while, but it's becoming better and better. And you get a wire across, and then of course it emits a laser, which has a burning sensation, but it also creates a cavitation, a waveform that will debulk and create a vacuum in a way. That's that cavitation process. And we slowly advance it. And then when we're done with that, now we can start thinking about what other tools we might use. Balloons, stents, the atherectomy, the lithotripsy, which you'll see shortly. So this at least gives us a pathway to start using our other basic tools. Really neat, advanced thing. I think we just adopted it about 6 months ago. I think the machine's like 500,000. Everything in the cath lab is dumb expensive, but it saves lives, so it's worth every penny.
It's also, we use laser more often in the in-stent restenosis. So if you already have a stent in place, we're going to be using laser oftentimes for those patients to help open up the blockage inside those stents. Thrombectomy. So here's an example. So oftentimes we have plaque ruptures, and then your platelets all combine together, create a little clot or embolus inside your artery, and that blockage or that clot of blood sits there and blocks flow down the rest of your artery. So this is the thrombectomy or the penumbra called CAT-RX that goes in there, and we use a little suction device to go in there, a little straw, and it sucks out that clot, puts it into a cool little canister. We're able to flow through it and then see what the clot actually looks like afterwards. So sometimes we get long clots that have actually come out of arteries. And these are often, I mean, these are sometimes your STEMI patients, the patients that are coming in because we had a very, very acute plaque rupture, and that's what created the clot, closed down an entire vessel really fast. And then we go in after that, place a stent, balloon, and place a stent, and we're all fixed up.
These patients are really in a lot of pain because when you create the other disease we have is occlusive plaque that's chronic, right? I'm just old, I'm not as strong, I'm tired, I'd take a nap. And all of a sudden you start having chest pain, you come in and we fix you like we did the other ones. This is the person that has disease, maybe it's 30, 40%. Plaque or atherosclerotic plaque is like a jelly bean. Let's say half a jelly bean glued to your wall. The outside's kind of crunchy and crispy, pretty firm, right? The inside's gooey. What happens, it can rupture the outside edge and the gooiness leaks out into the bloodstream. Your body sees that as a foreign or a bad idea. It creates an incredible cytokine release, interferons, interleukins, and inflammatory process, which makes your platelets want to go right there and shut that down. The problem is those platelets aggregate together so much that they create a blood clot. This is an acute bad syndrome. Usually this is a STEMI, a heart attack. This is why statins are so important. Not so much because they make you live longer per se. It's like a 1% life. It stabilizes that outer crust of your atherosclerotic plaque. It makes it more resilient, tougher, less likely to rupture, less likely to leak, less likely to lead to this. So that's where statins really are, their strength is in. So anyway.
Yeah, basically what he's saying too is like if you were to cut your arm, your body creates a scab, stops that blood, from coming out of your body, of course. Same thing's happening inside your arteries. It's the same reason that we're going on dual antiplatelet afterwards, because we don't want all those platelets to group up together and create a clot inside your stents afterwards.
Okay, so this is that lithotripsy. So this is a balloon angioplasty,
placed
just like the
at the
balloons you
lesion
saw.
using marker band.
But this is the Shockwave. That's the brand we use. It's the leader, and it's synonymous with lithotripsy balloon angioplasty. It's like Kleenex. They're facial tissues, but we call them Kleenex. So it's a balloon. You inflate it at a very low pressure. The other ones we go up to 15, 18 atmospheric pressures. This is at 4 atmosphere, barely enough to actually crush the goop away from the artery, but it gives an impulse. And by that impulse, it creates that cavitation. It breaks that calcium up, like your kidney stone, unfortunately. And you can see it just kind of pulverizes it. Very safe. And in my opinion, the atherectomy tools are very necessary. They're a great tool, but I love it when we use these instead if we can, because I think they're safe. There's a lot less involved. We don't have to give medications. There's risks with doing the spinning stuff, but these have less risk in my opinion. And again, that's anecdotal. I don't have the stats and the N value and the P value for you, but from what I've seen, this is a fantastic new technology that is thriving, and the doctors love it.
And all these devices are all really doctor preference. We've got a big toolbox full of all kinds of things we get to use, different catheters, different devices like this. And honestly, it really comes down to what the doctor's preference is, what he likes to use, he or she likes to use.
And you don't feel any of this, by the way, other than the fact we're occluding blood flow. You don't feel the waves. Your arteries actually don't have pain sensation. What you feel is that anaerobic event in your heart that makes you have heart pain. So it's not painful.
All right, so we have our Impella CP, our left ventricular assist device. So this is one of our coolest devices, I think, by far. So what it's doing is sitting in your left ventricle. This is a great video of it. So we're sitting in our left ventricle right here, and we're basically pulling all the blood flow from the left ventricle across the aortic valve into your aorta, where it's then able to go ahead and provide blood flow to the rest of your body. So this is what we use when we are doing protected percutaneous coronary interventions for those left main patients, higher risk coronary disease. We can put these in place, and we can go ahead and supply your body with a whole bunch of blood flow while we're shutting down all the blood flow to your heart or to your arteries. We can supply about 4 liters of blood flow with these. Normal blood flow for our bodies is about 4 to 6 liters. So for these, we can get almost 4 liters, and they can also stay on these for about 4 days. The Impella CP, or the left-sided Impella, is also really great for our cardiogenic shock patients. These are the patients who have had those full cardiac arrests, who've been brought in not alive or barely alive, and they come straight to us, and we get a pump in them as fast as we can, so we can go ahead and support the rest of their body, get blood flow out to their toes, so that we're not losing toes, we're not losing all of these things, we're not shutting down our blood flow to our kidneys and all of our other vital organs, so it's gonna help save our body. And then we're able to leave them on them for days after these events happen, and often can support their entire system for those days, and then we just wean them off of it. We also have an Impella that supports the right side of your heart as well, so we can do something really fun called a bipella. We can support both your left and right blood system at the same time, which is quite incredible. I think I got to do the first one here.
Yeah. Okay, so just a little bit on that. I'll give you a little story. When I first started in the cath lab, brand new, didn't know anything. I was super scared all the time. Maybe you know Dr. Hackshaw. He's been around forever. He's like the emeritus. He's the godfather. He was still doing caths. He was still doing interventions. And we did not have that Impella therapy yet at all. And he had one of his closest patients, probably a friend, family. And I came in the room, and they're like, we're doing an unprotected left main stent. which means we're going to stent the widowmaker. And he's got compromised blood flow. He's very weak. He doesn't have a lot of reserves, as we call it. It was theoretically a death sentence, but he was willing to take the chance, as low as it was. And I remember just being so flabbergasted by his honesty. And he brought the patient's family in the room before we got started. And before we draped him sterilely, they kissed him and they basically said their goodbyes, because we really anticipated him to die on our table. It was horrible. It was horrific. I was new. I didn't know how to cope really. And I was so afraid, and it worked out great. So FYI, it worked out great. But with that pump, we don't even think about it anymore. We do left mains like they're tying your shoe now, basically. And that's hyperbole, but there's not this grave aspect of fixing these really scary, scary vessels anymore, because that's like insurance. We can stop blood flow to your heart muscle and you will stay alive. Your brain gets blood, your toes get blood, your kidneys get blood, your liver. It doesn't impair you at all, despite your heart not getting blood flow. So it's a game changer for people. Absolutely. So anyway, it's a wonderful product. TAVR, it's big, exciting. We've become this incredible TAVR center. They actually bring people from all over the country to come see us do it. Not only do we do it well, we do it incredibly efficiently with our tiny little cath lab. We're a tiny little hospital compared to Hoag, San Diego, all those. We actually do more before noon than anyone else in the country does.
I think we had like what do we do? We did like 6 before.
We've done
like 1 o'clock or something, which is
we do 6
unheard of at this point.
Sometimes, and nobody else does that. So, and that's coming from the vendors who go everywhere. So we're
Quick,
hitting up,
efficient.
et cetera. So that's not a helicopter coming in. That's us patting ourselves on the back. So TAVR, we're replacing your aortic valve. You have a stenotic aortic valve. It's become narrowed for one reason or another. Again, it's like when you put your thumb over a hose, it gets really hard and fast, right? That's not good in your heart. Your heart has to work hard. It makes you short of breath. You don't get to do what you want to do anymore. Your life can completely be unended where you cannot enjoy anything because you're so sick, because your aortic valve is so tight. So what we're going to go in is we're going to go in there and put a stent basically with a new valve. And it's bovine, it's cow. And at the facility where we use ours, Edwards, they have these guys and gals that they are the only people that sew them on by hand. Each one is handmade. And they're in this perfectly sterile room. They've worked there for 25 years. There's only a handful of humans on the planet that can do that. So it's incredible what they do. So basically we go in through your large arteries. It is a large vessel. We use it down in our OR12 and we go up. And you're kind of awake during this process. We don't put a tube down your throat and knock you out. We kind of keep you in a happy place, which is incredible. We put it across your valve. They've done all that work up with our previous casts. And then this is going to sound scary. We rapidly pace your heart. We make your heart go almost 200 beats per minute to the point that it's really not able to even, it's just kind of quivering, because we don't want a good pump because it'll move our equipment out. And that would be bad when we're trying to deploy this thing. People do really well. We do very short, but then you can see we blow up the balloon like a stent and it expands it perfectly where we want it. And it crushes the old stenotic valve that you were born with out of the way. And then we deflate the balloon and the doctor says off pacer, and Monica and I are sometimes on the pacer and we take off the pacer really fast. So it's one of the things we do.
So another is just a kind of a fun image. So right here we have a temporary transvenous pacemaker or a, well, it looks like
it's a temp pace, yeah.
Yeah. So we have a pacemaker here. You can see that the heart is quivering because we have it rapid pace at 180 beats per minute here. We have a wire coming into the heart as well. We have another catheter sitting up there at the very top. You can see it kind of twist around up there so we've got 3 different things in here on top of the device just to get the procedure done.
And people feel so good after this is done. It changes lives. So it's wonderful. It's wonderful that we get to be a part of that team that does that for folks. This is the mitral clip. This is your mitral valve. The aortic valve is the valve that is between your ventricle and your aorta. This is the mitral side. So this is the side that flows back into the right atrium or left atrium, excuse me, and can go into the lungs. So, and this is where your valve should only go in one way. This one is going backwards. So you're regurgitating blood back against stream, can cause shortness of breath, discomfort, swelling in your arms, etc. There's a lot of symptoms, and people don't do great with this, and it makes their heart become exceptionally weak in areas that can't really tolerate it. So we go in through the vein this time. This is the venous side. And so then we go in and we actually capture those leaflets in the middle, usually, and then we bring them together. So we make like a figure eight or an infinity symbol. And that way you don't have as much backflow back into your lungs, and you don't get short of breath and things like that. So this is also another structural heart item that we do. These folks don't have as dramatic of a post-procedural response. I think it's not as exciting and big as the aortic valve, but the aorta, again, this is more right-sided stuff. That's left-sided. Left gets all the famous stuff. So, but people do better. They do better. They can come down medications. They feel better. It just takes longer for them to realize it. Find.
And coming up, we actually have a tri-clip. So we're going to have a tricuspid clip, very similar, looks almost identical to this, that we can place in the tricuspid portion and as opposed to the mitral valve. That's where we've yet to do, and we're hoping in the next probably 6 months we'll do our first one. New technology. Let's get into it.
Let's get into it.
So lithotripsy, shockwave that we talked about to break up calcium. That's one of our newer procedures that we use quite frequently. We've been doing that for the last year or two probably at this point. Leadless pacemakers. That's a very specific pacemaker that just sits in your right ventricle. We have a little one to show you for that. This pacemaker is honestly fantastic. I thought I had a picture of it. I probably do. But it's just a single little device that's smaller than the tip of my pinky. There it is right there. And this device sits in the right ventricle and it's able to pace. So this is for patients with bradycardia. And we're able to do it all through a vein, very similar to that MitraClip procedure. We're able to just suture up that groin, and it's pretty, I mean, we place these in about 10 minutes. I think the downsides to this specific device as a pacemaker are going to be the lifespan of it. It's not going to be great for your 40, 50-year-olds with bradycardia because the lifespan of this battery, it's a battery. We don't have anything that we can change externally like we have other pacemakers. When we have other issues with batteries for pacemakers, we're able to just cut into that skin where we placed it originally, change out that generator, attach the leads, and go on for the next however long. For this one, though, lifespan's only about 10 to 12 years. So we're probably not placing this in our younger patients. I think we put it in like a 66-year-old this last week, and that's on the younger side for us because now we're thinking we're going to have to place 2 or 3 of these. Right now, I think it's been tested that we can fit about 3 of them inside your heart, but every time we're putting more stuff inside the heart. So, I mean, 70, 80, okay, we could probably do this. If we do have to do 2, 3 of them, then that's okay. But longer than that, we're not going to be able to use them. Laser atherectomy, that's a newer one for us. It's also dependent on doctors. I think we only have 1 or 2 of our doctors that are actually certified or trained to use our laser atherectomy. For a long time, we were actually sending patients out to Scripps to get this done if they were having multiple in-stent restenoses. Drug-coated balloons, this is something that we're kind of excited for. We've been using them, we use them in legs and stuff. We have larger balloons for these, but this is something that's up and coming. We have not done them yet. We don't even have them in stock yet, but this is something we'll be seeing, I think, in the next year probably. It's going to be drug-coated balloons that we're able to use on those smaller, on the smaller disease that we're seeing in the heart. So for those patients that we could not place a stent because we couldn't fit anything in there, we don't have a small enough stent for it, we can use, the goal is that we'll be able to use drug-coated balloons in place of that, and it delivers a drug that's able to help keep it open. Pulmonary embolectomy, it looks like we're maybe coming down the line. We're going to start, they've been doing these in interventional radiology when we have pulmonary embolisms or blood clots in the lungs. That's something that we now have a doctor who's also trained on these. He's trained at a lot of different places. So the goal is that maybe we'll be doing really, really bad pulmonary embolisms. So we're going to start doing these, I guess. And then the tricuspid valve, that's coming up too, just like the MitraClip, but anything to add?
Is that it?
Yeah.
Are we done?
Oh, here.
Oh, okay.
Picture the leadless pacemaker for size. Go ahead.
Yeah, it's leadless pacemaker, Penny, we all pretty familiar. And so we deliver it onto the right ventricular septal wall. And between the rep and the doctor, they know all this number stuff, which always makes me go cross-eyed. But anyway, when they find the perfect spot, they release it. Anybody a fisherman, they've ever used a treble hook? It's not unlike that. They've got these tongs that are retracted back, and when the contact point is in the perfect spot, they talk about milliamperages and stuff like that. When they're happy, they advance these and they curl over, and in doing so, they kind of dig into that internal wall, the intimal wall of your ventricle, and they actually like come back out. So they hook themselves into the meat, and then we want to make sure we have a couple of them that hooked, because then we know it won't ever dislodge and go away, which would be bad. And that's what those are. And so once we're there, you're done. There is another brand other than Medtronic that actually is retrievable. It's like a corkscrew on your wine key. And we can put that in. It is more complex to put in, but if it goes at the end of life, we can actually go in with a new one, put a new one in, and then screw that one out and take it away. And you're less likely to have a bunch of stuff floating around in your ventricle. But there's a lot of new advancements coming, and they're getting smaller. I mean, this is incredible. This is insane. This blows my mind, because we can help people and not have to cut them open, risk an infection, et cetera. It's game changing.
And the goal with this is that eventually it actually grows into the wall of your heart. So it's not just hanging on by those tines or those hooks. It's grown into the wall with scar tissue. All right.
Okay, well, that's the
That's
end of
it.
the slides.